Audible? Huh?
Yes, sir.
Yeah. इस स्क्रीन शेयर करके देखूं?
हाँ जी, हाँ सर, एक बार।
हाँ।
Yes, sir, it's clear now.
ओके, हाँ, ओके।
सर कुछ देर में करते हैं स्टार्ट अभी।
ओके, 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 कोई बात नहीं।
तो स्टूडेंट्स अभी एंटर हो रहे हैं।
हाँ, नहीं, होने दीजिए, होने लगा है, कोई बात नहीं।
Associate Professor, Veterinary Medicine, GADVASU, Ludhiana. This webinar is being organized under Institutional Development Plan of NAHEP, the National Agriculture Higher Education Plan, under the dynamic leadership of Dr. SPS Kuman, the PI of this scheme and Dean of College of Veterinary Science, Ludhiana. Our today's speaker is very distinguished uh, professor, scientist, clinician, academician, Dr. J.P. Varshney. He is with us. He has more than 50 years of experience in veterinary medicine, particularly in canine cardiology. He has he is the pioneer in this field, uh, and he has guided many students on this subject and authored many articles, research articles, and books. Recently, he has published one book on ECG based on his clinical experiences. That will be a very beneficial to all the veterinarians and veterinary graduates. Uh, so, keeping in view of his vast experience on this subject, we requested him to deliver one webinar on this subject, and he accepted our request. This we are very thankful to him. Now I'll request Dr. J.P. Varshney ji to deliver his webinar on this subject topic: diagnosis of canine cardiac diseases, practical approach to veterinary graduates. So over to you, sir. Thank you.
Thank you, Dr. Gupta. At the outset, I would like to express my sincere thanks to the authorities of the Universe GADVASU to giving me the chance to interact with the veterinary graduates. As you know, I have been assigned a topic, diagnosis of canine cardiac diseases, a practical approach. So, as a veterinarian, our prime responsibility is a diagnosis. Let us understand what is diagnosis. If we say heart disease, if we say arrhythmia, are they disease diagnoses? Actually, if we see, these things are not diagnosis. When we say diagnosis, diagnosis means it is to identify the disease and its process and correlate the clinical manifestation with an understanding of etiology and its impact on organ and function of a main organ and distant organ. So when we say a left heart enlargement, in our mind it comes that it is only the left heart, it may affect the lung, it may affect the forward failure, it may affect the backward failure also. But when we say heart disease, it does not mean any. So correct diagnosis. Diagnosis means then you have to assess the whole process with the manifestation, understanding of manifestation, and an eye on the etiology and a assessment of what organ can be assessed. Then this is called diagnosis. Then actually question comes, why to make a diagnosis when we have an arsenal of the drug, we can use multiple drugs, and we can just by symptoms we can come to some conclusion and treat the animal. No, the major contribution of diagnosis is that it avoids unnecessary use of the drug. When you use multi-drug therapy, there may be many interactions, and there may be the toxic effect also, and the drugs may not be effective. So if you make an exact diagnosis, you avoid unnecessary use of many drugs. By reducing the use of the drug or restricting to the rational drugs, you reduce the load on the body metabolism. So body is at ease. Recovery will be faster. Less drug, faster recovery. When you give less drug, there is less toxins produced, then there is less damage to environment. Whatever drugs metabolize, they are passed through urine and feces, come to the soil and disturb the ecosystem, microbial system. So as a veterinarian, it is our responsibility. We do the minimum harm to the ecosystem. So that's why you have to have an exact diagnosis. When you are damaging less to the system, then you are eco-friendly doctor. You are making balance between nature and the animal. And then when these things are there, recovery is faster. Recovery is faster, then it reduces the cost of treatment. So it is a owner friendly, patient friendly, and environmental friendly. In these, this is your contribution to the surroundings if you make a diagnosis. Then comes as the topic of today, cardiac disease. What is cardiac disease? Is it the heart disease? Yeah, cardiac disease means it is involves only the heart. No. When we say cardiac disease, it involves the heart as well as vessels and even the lung also. These are together. Three organs together, heart, vessels and lungs. In cardiovascular system, this is the diagram which shows you the heart. Heart has a different component: ventricle, auricle, pulmonary artery, pulmonary vein, aorta, tricuspid wall, mitral wall, pulmonary wall, like that. And then other major vessels. Then comes actually what heart does in the body. So we have to be careful in diagnosing its disease. If we understand its function, we can easily recognize the malfunctions of the heart. The first important function of the heart is to pump the oxygenated blood to the whole of the body. This one is the blood, which is containing oxygen. And other nutrient component like hormone, vital substances, vitamins, others are also circulated throughout the body by the heart. By doing this, this heart maintains the blood pressure. That maintenance is very, very important. And also it receives the deoxygenated blood, which carried the metabolite base again, and then send these waste product metabolite deoxygenated blood to the lungs. From lungs, it takes the oxygenated blood and again push the oxygenated blood to whole of the body. So these are the functions of the heart, which are conducted through to diastole and systole. Systole and diastole, they are the important functions of the heart, which take care of all these functioning. Now, before we go in the other details, let us have a look how the heart takes part in the circulation, how it circulates the blood. And take the first step. The blood comes to through pulmonary vein, it comes to left atrium. Through mitral wall, it comes to the left ventricle. This is an oxygenated blood. And from left ventricle by systole, it goes to pulmonary artery and it goes to aorta and distributed to the whole of the body. So this is the first part of the important function of the heart, which is produced, which is carried out by the left ventricle. Simultaneously, in right atrium, the venous blood comes through superior vena cava, means cranial vena cava, and the ventral vena cava, and from other veins it comes to the right atrium. From right atrium it comes to right ventricle through tricuspid wall, and during systole it is pushed to pulmonary artery and goes to lung for deoxygenation. So this is the nutshell a circulation diagram, how the blood comes and how it goes. If any, by looking this, my emphasis of showing this is, if anything goes wrong with a mitral wall, tricuspid wall, aortic wall, pulmonary wall, or wall of the ventricle, then the heart gets sick. Now comes to what are the cardiac diseases? Is it one disease or is it a group of disease? As the cardiac anatomy consists of many different parts and has to carry out the two different functions, the dysfunctioning of them results into the cardiac disease. First we take, if something wrong happens with the wall, ventricular wall. Then it may affect the systole and diastole. So the cardiac diseases includes the systolic dysfunction and diastolic function. As with the valves, if somehow valves are not patent, they are leaky. So there may be valvular insufficiency. And then there is a septa between both ventricles, interventricular septa. And if septal defect is there, also heart is abnormal. Then major vessels like aorta, pulmonary vein, pulmonary artery, they become sick, there is some disturbance, then also heart disease is there. This is the related with the anatomical structures of the heart. Now comes the physiological functions of the heart. Then how the current generate. There is a seat at right atrium that is known as SA node, from where the current generates and is spread to the whole of the heart. So the defect in generation of the current and its conduction will also lead to cardiac disease. And these type of cardiac disease, impulse formation and conduction, impulse conduction and impulse formation, they are come under the arrhythmias. The arrhythmias are more common than the any other disease of the heart. So these are the three types of the disease: valvular disease, valve disease, ventricular wall disease, and the generation of current disease. So these three group of the diseases constitute heart. Question: how does heart get disease? What is only the heart? If it is some abnormality of structure or function, there is a heart disease. Or there can be the other ways also. The heart may become diseased when the other organs in the body are diseased. That's why I see this flow diagram. I have divided these all things into in the heart itself. When heart itself is affected, it can be affected in a cardiomyopathy when the ventricular wall is diseased. It can be diseased when the valves are insufficient, they are incompetent, then their valvular insufficiency will be there, septal defect will be there, and then nervous system may be defected, sympathetic and parasympathetic. If both are defected, they may lead to arrhythmias. So these four type of the disease originate from the heart itself, where the heart gets sick. In other conditions, there are more conditions than them when the heart gets disease. This is a secondary heart involvement that is equally important as the primary. The other than heart, the organ which can affect the heart functioning are trauma, somehow and fall, or chest trauma, or vertebral trauma, or severe fractures. They can all affect the heart. Then diseases of kidney, liver, thyroid and brain. They can also affect the heart functioning. So heart may be diseased there. Then metabolic disorder like eclampsia. This is adrenal defect, and then thyroid defect. They can all affect the heart functioning. Then in nutritional deficiencies like taurine and carnitine deficiency, vitamin E deficiency, vitamin B deficiency, protein deficiency. They can all affect the functioning of the heart. Then comes the toxins. Toxins because of metabolite. Toxic may be toxic substances or maybe snake bite or scorpion bite. If they occur, they can also affect the heart. Then the inflammatory disease. This is the recent emphasis which is being given on cardiac diseases. If any sustained inflammation of any organ in the body having a multi-systemic effect will affect the heart. Then neoplasia, tumors. If tumors are there elsewhere, they will also affect the heart. Then some idiopathic, where causes are not definitely known. Then protozoal, ehrlichial and other infections, bacterial, viral like viral parvo, distemper, and in bacterial endocarditis like streptococci or staphylococci or pseudomonas, or like protozoan diseases like Babesia, and they can all affect the functioning of the heart. Then anaphylaxis or allergy, they can also affect the functioning of heart. So all these diseases occurring whether in the heart or away from the heart may affect the heart functioning. So heart disease becomes a very wide thing, and it has to be diagnosed whether the malfunctioning of the heart is primary or secondary. Now coming, then how we have to conduct the cardiac examination. Is cardiac examination means examination of the heart only? No. When we say the cardiac examination, it is the examination of heart and associated structures like lung and blood vessels. When you see the functioning of heart, for always look for jugular pulsation. So major vessels has to be seen. Then always look for rails in the caudal part of the lung when the heart disease is suspected. So it is a examination of lung also. Always examine the heart, lung and vessel whenever you suspect cardiac involvement. Now, what we can get from heart examination? Two important is there which we can get from a heart examination. One is we can assess the health of the heart and vessels in a regular interval. So it can be a part of normal or periodic medical examination or in geriatric patients also. And second important thing is by examining the heart, we can detect the underlying heart issues. Now coming to the main thing, how the cardiac diseases can be diagnosed, what are the techniques available which are employed to diagnose the cardiac disease. So we start from first, that is the clinical manifestation. What type of the signs are being exhibited in cardiac disease? We will come when we take in detail. And this examination, physical examination, is facilitated by the stethoscope. Stethoscope is a very good tool. It is a insignia of our profession, and this can tell many things. So I will come to it when I take it in detail. Then blood pressure examination. We can also examine the blood pressure and can know the status of the heart. Then we can go for radiological examination, X-ray. X-ray, we can go for X-ray of the chest and X-ray of the abdomen. Always we should examine the chest and abdomen together through X-ray. Then comes the next technique is electrocardiography. This is an important tool by which we can know many things through electrocardiography. Other is a interventional technique, which is catheterization or passing a catheter and doing many things. This is more of a scientific interest or academic interest. Then comes the echocardiography. Echocardiography, and then in last, not the least, is a cardiac biomarker. Cardiac biomarkers are the tools which can not only tell you the damage to the heart, but some of the biomarkers are now available which can tell you that your patient is going to have a heart problem. So these 8 things constitute the diagnostic protocol for examining the heart. Now we take first, that is a clinical approach. In clinical approach, there are 2 important things: history. As we know that history is important for diagnosing anything. When we have conduct any examination, history is the first part and it is to be thoroughly examined. So what are the historical points which a owner can reveal by which you can suspect that heart is compromised or heart is not functioning properly? The first thing most of the owners say, the appetite is erratic. They may say the animal is not eating at all, or they may say animal has become more choosy, or sometimes it eats, sometimes does not eat. Then they may show that there is a coughing, nocturnal coughing, even night coughing. The animal, the dog is coughing all the night or in a particular hours of the night and prefer to remain standing rather than lying. Such type of study. Growth is not proper. Ill thrift, animal has not developed normally. And when the animal is made to exercise or to move, the exercise intolerance is there, weakness is there. Sometimes animal gets fainting, and there may be discoloration of the tongue sometimes, or suddenly, or the conjunctiva is muddy or congested, and then there is maybe a weight loss. So these are the 8 characteristics which history may reveal. If the owner is able to tell that these combination of these characters are there, you may suspect that there could be a heart problem. Now coming to our part as a veterinarian, which we have to uh, do. As a veterinarian, most of the diseases are diagnosed by history and clinical examination. By history, you can diagnose the diseases to the tune of 30 to 35%. If you add clinical examination, you can go up to 65 to 70% diagnosis. So 70% of diagnosis is in your hand. So please, this the 35 and 70, about 35% is depends on your examination. So these examination technique for the heart are the similar as for the others. Then go for inspection, general inspection. What are the points which you should look for the heart? That is a jugular vein. That is jugular vein distension. If jugular pulsation is there, then you can suspect that there may be a right ventricle problem, right heart problem. The heart is compromised. Heart is, this is a congestive failure is there. So examine for jugular pulse. Swelling in any part of the body, there can be a swelling, edema, then there can be the respiratory change. If animal is fainting, not able to take breathe properly, or there is a more thoracoabdominal respiration. So by inspection, you get these things. Then comes the percussion. If you find some swelling, you can percuss and find the fluid thrill. If fluid thrill in the abdomen is there, then that ascites could give you a chance that it could be of a heart origin also besides the liver and kidney. So percussion will also helpful to you. Then we go for palpation. Palpation of heart, that is the position at the apex beat, then precordial thrill and femoral pulse you can palpate, and also palpate the abdomen for liver in the right side. In heart diseases also, there is an enlargement of the liver which protrude through the rib cage. So you may be thinking we have to see for heart, why we go for liver? Well, because there is a hepatic hypertension. In hepatic hypertension, liver is enlarged because of the heart problem, because of congestion. So do not avoid the examine the abdomen also, even in the heart disease. Then CRT, capillary refill time. This is a function of circulation. If circulation is compromised, then capillary refill time will be increased and color of mucous membrane is also changed. If severe anemia is there, it will be pale. If the congestive problem is there, it will be cyanotic or will be little cherry color. Not exactly cherry color, but blue stage. Or mucous membrane may be dry. So CRT and color of the mucous membrane is also an important part of exam. Now we comes to and another tool which is handy, it always remains with us. We can make use of we can make a right use of it. That is a stethoscope, that is auscultation. what we can get from auscultation? Auscultation, we can examine the heart and can know the rate, what is the rate of heartbeat, what is the rhythm, it is regular or irregular, intensity, whether it is loud or strong or weak, or detection of murmur. And then go for examining of the lung, particularly in a caudal part of the lung where you can get rails. So this is a very important tool. Then what are the clinical detection which you can detect by in a heart disease? This is, you will find that there will be exercise weakness, exercise intolerance, animal is feeling weak. This is a function of forward failure. It means the blood circulation is not reaching to the periphery. Then congestive. Then there may be the spleen and hepatic maggot. Liver and spleen may be palpable, high. Then murmurs. Murmurs will give you an idea of this leaky wall. There may be valvular insufficiency, maybe tricuspid, maybe mitral wall, maybe pulmonary wall, maybe the aortic wall. Then mucous membrane examine, as I told you, it may be pale because of anemia, because forward failure is there. It may be cyanosed because of a backward failure. The blood is not going back to the heart. Then dry and tacky mucous membrane. If mucous membrane is dry and very tacky appearance, then it is a congestive phase. Then wheezing or crackles. These wheezing or crackles will be audible in a caudal part of the lung. Then comes the extremities. Extremities become cool. Why cool? Because the blood is not able to come to the periphery. Heart is not able to pump blood with a force that it can come to periphery. So pulse, all the pulse, ear pinna, they will be bit cool than the whole body. Then there may be lungs problem. When congestion in the lung is there may be dyspnea, panting, coughing, particularly nocturnal coughing. Then slow CRT. This is a sign of forward failure. Blood is not coming to the mucous membrane, so capillary refill time is increased. Good. And then effusion. There may be two types of effusion. One may be the pericardial effusion, where there will be more fluid in pericardial sac. Another is a peritoneal effusion, where the more fluid in peritoneal cavity. So ascites may be there. Even this pericardial effusion may be there. Then precordial thrill. When you auscultate, you find the thrills over the heart at the apex of the heart, which will be you can see visibly. Then distension of the jugular vein. Distension of jugular vein is the indication of right heart failure. There may be pulsation of jugular vein. Mind you, there are two types of jugular pulsation. One is a true, other is a false. When you put the pressure, it will not stop. Then it is a true. Then arrhythmia. Arrhythmia, the heart rate may be not normal, rhythm may not be normal. Sometimes you find heart rate by auscultate is suppose 140. When you look at the pulse, it is 100 or 120. So this is a pulse deficit. These things both have to be correlated. When you take the pulse, you specify its strength, whether it is a weak or it is a strong pulse. So they will indicate different type of nature. Suppose it is very strong pulse, then it could be a sign of hyperthyroidism. And if it is a weak, it may be due to heart is not able to pump the blood to the periphery. That's why the blood is not coming and your pulse is weak. So such type of the signs may be detected while you examine them clinically. So they should be taken into account and try to correlate them. Next comes the what animal manifests, which you have to detect. Though they are intermixed things, clinical detection and clinical manifestation by animal itself. First picture you see, it is a distress, open mouth breathing and reluctancy to move. And then second, this is a pup showing severe dyspnea, not able to stand, always gasping. This is a severe dyspnea. Then lymphedema. Lymphedema, do not expect lymphedema only in liver. Lymphedema may be in heart disease also. Lymphedema may be in kidney disease also. And lymphedema may be in liver disease also. So this is one of the signs which may occur in the heart disease also. Just mucous membrane may be pain or sinus. Ascites, here you see ascites. It does not mean that it may be of heart only. It may be of liver, it may be of kidney. So we have to identify. Then orthopenia, only the animal feeling comfort in standing, not lying down. Animal will reluctant to lie down. Then syncope, suddenly fainting. Animal become faint. It may come to hospital, may become faint. And then congested conjunctiva, the color is dirty, bluish tinge. So such type of a backward sign of backward failure. So these type of the clinical manifestation animal may show. Now coming to auscultation. Okay, this is a insignia of the professionalism. Everybody is doing the stethoscope, but this is a very important tool. We have to justify with auscultation. We have to be serious in auscultation. We are not simply just to put the bell over the chest and forget it. We have to be little more precise in auscultation. First, I give you a background about the stethoscope. How this auscultation is facilitated by the stethoscope. Stethoscope took birth in 1816. Before the advent of the stethoscope, physician was putting the ear over the chest and hearing the sound. It became sometimes very awkward when the patient was a female and you want to know the heartbeat. So it was a very difficult time before 1816 to examine the heart or to examine the intestine or other things, because they require a close contact of the ear and the organ. So this was very difficult time. So it was a René Laennec. It was a French physician, and he thought that it is how to circumvent this thing. One day he was in his clinic. A lady patient came. It was really in semi-conscious condition. So he was perplexed how to see whether heart is functioning or not. Luckily, there was a paper lying before him. He took the paper, rolled it, make it a pipe, put the pipe and put the ear at one end and other end on the chest. Then he was excited that it could be better to from here. This was the development stage of stethoscope. But then he took, this is the original drawing which were at Laennec time, which is a wooden one, which was used to auscultate the heart. Then diaphragm was all developed later. This is the wooden piece which later Laennec used. So at that time, this stethoscope was mono-oral. Only one tube was there. Only one ear you can put. Only at one place you can see. Then development takes place and diaphragm came. And bioral stethoscope came in 1851. And the inventor was Arthur Laird. This was development, and this is the today's stethoscope, which is everybody is donning, and it consists of their ear knob, ear tube, then tubings, and this is a diaphragm, the bell and diaphragm. So this is very very useful and easy to auscultate the heart. as you know, when this was developed, the idea of auscultation was developed, it was given a name of stethoscope, because at that time it was only in their mind that they have to hear the heart sound only, examine the chest only. So this is a Greek word, stethoscope. Sthesos means chest, scopos means examine the chest, and so it was used for heart. But stethoscope can be used to examine not only the heart but also to lung and intestinal sounds. So this is a important tool with us which can lead us to suspect the heart disease even by first examination. Now, where to auscultate, or where and what are the points to be auscultated? Is it simply just you put a diaphragm anywhere on the chest and get some idea? No. There are important 5-6 points which you should always take care. So by auscultation, you can get the idea about the heart rate, heart rhythm, what is the intensity of the heart sound, and whether murmurs are present or not. These 5 things is the characteristic thing which you can note through auscultation of the chest. Then this is diagram, this is the left side. Here at the point of elbow, this is third intercostal space. If you auscultate here, the sound will be of pulmonary wall. You go about 1 or 1.5 centimeter dorsal towards the fourth intercostal space, then you can auscultate the aortic sound. And if you come to ventral part downside and on the fifth intercostal space, fifth or sixth intercostal space, in between fifth and sixth, you get the mitral valve sound on the left side. Mitral valve sound is little away. And when you go on the right side and fifth intercostal space, just 2 centimeters above the costochondral joint, you can find the sound of tricuspid valve. What this diagram shows, or what I tells you, does not mean that valves are situated there. These are the point of maximum sound of these valves which can be audible. So auscultate for these 4 points for the patency of these valves: pulmonary, aortic, mitral, and tricuspid. Besides this, you have to auscultate the base of the heart and the apex of the heart. So these are the 6 points. While you examine the heart, auscultate at 6 places. And you can, when you will auscultate, you will differentiate the nature of the sound. Then go towards the dorsal side and caudal side. Then in this last triangle, you auscultate whether there are the rails present, whether they are moist or there is increased sound, or if rails are present in a cranial side, they will give you an idea whether it is a lung disease or heart disease. If rails and crackles are present in a cranial side, it is not a heart disease. If they are present on a caudal side and, of the lung and hilar region, dorsal hilar region, you will find the rails, then it could be the heart. So this is the importance of a auscultation of the chest. Now this is the diagram to show the area where you can get the murmurs on localization. This is the left side of the chest, where you can get at the base, on base and cranial side, the patent ductus arteriosus. The murmurs due to patent ductus arteriosus can be heard over this place. When you come at the base, near the 5th to 6th intercostal space, in between, you can get the murmurs of mitral valve. And then on the right side, when you go, and then you can get the ventral septal defect about the 4th intercostal space, fourth intercostal space, no, 3rd intercostal space. And when you come to 4th intercostal space on ventral side, just near the costochondral junction, you may get the sound for tricuspid valve. So differentiation in these two locations can help you to speculate which valve, which defect can be there. So this is very important. Now the coming to murmur. Murmurs are very important abnormal sound. It is just like a narrow pipe. You are blowing the sound with a force. So such type of the sound, they are produced, they are known as murmurs. So there are 6 grades of the murmurs. They are classified 1 to 6 on the grade of murmur when and where you are able to hear the sound. These murmurs, if you are audible at when you are listening very carefully, auscultating the heart, all the 6 points, if after 1 or 2 minutes auscultation, you find some murmurs, then you can classify them as grade 1. If the murmurs, as you put the stethoscope and you are able to detect some murmur, then they are of grade 2. And then there are some murmurs which are parallel to the heart sound, which are like a heart sound, then they are 3rd grade murmur. When they are louder than the heart sound, then they are a 4th grade murmur. So they are without thrill. There is no thrill in murmurs, while heart sound are associated with thrill. And then if they are louder than the heart sound with a thrill, then they are 5th grade murmur. And 6th grade murmur, if you put a stethoscope anywhere on the chest and heard the murmur, they are the 6th grade murmur. So these are the classification of the murmurs, which can tell us which valve is affected or compromised. And this is with the history and clinical. Is it all? If we are knowing so much through these examinations, then should we go further or not? Yes, we have to go further because everything has limitations. The ancillary approach, which consists of history and clinical examination, does have limitation. The first limitation is that you cannot make a definite diagnosis of arrhythmia. What type of arrhythmia or conduction disturbance is there? Though you can say that rate is not normal or the rhythm is not normal. So, but you cannot go to the specific type of arrhythmia. Then दूसरा about the wall disease, that is cardiomyopathy. You cannot make diagnosis that it is a ventral wall or ventricular wall disease, left ventricle or right ventricle disease, because there is not much change in sounds of due to the cardiomyopathy. Then valvular or septal defect, definite diagnosis is difficult. Though you can speculate by auscultation that valve is defect or septa is defect, but not definite. So these are the limitations. They force us to go a step ahead. Then step ahead, the next step is the blood pressure monitoring. Is blood pressure monitoring now? Tools are available. There are simple tools because you can use the cuff, with neonatal cuff, which is used for human being. You can take the blood pressure in the hind limb and in some diseases like kidney diseases, there is a hypertension. So if you get the hypertension, you get the idea about the is not, or there is a hypotension, then you can get the idea there may be dehydration, there may be it may be due to the emesis, or it may be due to diarrhea, or there is a fall in blood pressure because of compromised blood circulation. So if they are there, then you can resort to a fluid therapy immediately if there is a hypotension to make the equilibrium of the circulation. So this is another tool. Now comes the third important tool, that is electrocardiography. Electrocardiography is a very, very important tool to tell us about the heart rate, heart rhythm, conduction disturbances, and particularly about the chamber size in dogs, particularly about dogs, not in all species. So this electrocardiography is a non-invasive tool. which consists of a voltmeter, simple voltmeter, and recording device. And then it is necessary, it can help us to diagnose and treat the arrhythmia. It can help us to monitor the electrolyte disorder. Because if you send a sample for electrolyte analysis to the lab, it will take few hours from going from your hospital to the lab and then analysis and coming the result. But if you examine the heart through electrocardiography, you can get idea whether there is some major electrolyte like calcium, like potassium. Their dysfunctioning is there or not. If that can be detected, then some extent you can get the chamber size, left heart enlargement, left atrium enlargement, left ventricular enlargement, right atrium, right ventricle. These type of enlargement patterns you can detect in dogs by electrocardiography. Then you can use this to monitor the health, the regular month health check, anesthesia, and surgery. Now, one thing I would like to emphasize that always when you give anesthesia, examine the heart, take the electrocardiogram to decide your anesthetic protocol and surgery. And then preventive evaluation, trauma evaluation. If you find the cases of accident, fall, or motor vehicle accident, always examine the heart through electrocardiography, because there is chances of chest trauma and there may be severe or fatal arrhythmias also. Even in case of bites, in snake bites, there is general practice, nobody examine the heart in snake bite. But the effect of this toxins, venom toxin, is there on the heart, and it develops after 24 to 36 hours. So snake bite patients should always be subjected to electrocardiography to detect whether that snake venom toxins has affected the heart also or not. Because sometimes you see that you treat with the snake venom and animal recover for some time but collapse thereafter. It is collapse is due to the compromised heart because of the toxins. So in these cases, electrocardiography is a very, very important tool. And you can evaluate the geriatric patient. And one thing always remember, that if ECG is normal, it never rules out, 100% never rules out the cardiac malfunction. Cardiac malfunction is not only of the valve, maybe of many other things. So do not rule out. There may be chance. With 90% it's okay. But if sometimes the ECG is showing some abnormality, but that means also not there, heart is always compromised. Okay, it is a vice versa. So everything is to be interpreted in conjunction with everything, every examination. So now, how the electrocardiography developed and what was the how it took place? The development started in 1842. In 1842, Italian physics scientist Carlo Matteucci get realized that heartbeat is associated with electrical activity. Because heartbeat, there is some electrical event which is taking place, because of that the heartbeat is there. So that was the beginning of the development of electrocardiography. Later in 1876, Murray, a Irish scientist, he analyzed the electrical pattern of the frog heart. He subjected the frog heart to the electrical event analysis, and he found that when the heart is pumping the blood, the diastole, systole, they were associated with the electrolytical pattern. Then the most important discovery took place in 1895 when William Einthoven, he invented the EKG, electrocardiogram, and he was awarded in 1924 a Nobel Prize for developing this. But he developed this electrocardiogram in 1895, but actually used it in 1906. when he used the string galvanometer or electrometer and diagnosed the heart disease in a patient first time. It was 1906. And in 1938, American Heart Association and Council of and Cardiological Society of Britain, they defined the positioning of chest lead. Chest leads were introduced in 1938. Up to this time, the chest lead, augmented leads were not there. Only the standard lead and chest lead were there. But augmented lead developed in 1942. That was a Goldberger. He made these leads available, and then ECG became a 12 lead examination. Before that, Goldberger, it was a 6 lead examination. Then this is the figure how the discovery took place. This is in 1903, William Einthoven, what he used to analyze the electrical activity of the heart first. Then this is the modern electrocardiographic machine. Now it is switching to the other type of electrocardiographic machine, which only one probe you can put on the chest and get all information. This is the latest development in electrocardiography. Now, this is the figure of Einthoven time when the first ECG was recorded. The both hand and both feet were put in a salt solution, sodium chloride solution, and then the heart activity was monitored. Then we are coming when you should consider that the patient or dog is to be examined for through electrocardiogram for ECG. Then first thing is, if you get any patient with a multi-organ dysfunction, maybe liver function, kidney dysfunction, maybe thyroid dysfunction, such type of cases should be referred for electrocardiography. Then if anesthesia in surgery, always before and after. Then pets with gasping or dyspnea, maybe small or large or geriatric, always they should be referred. Then geriatric old cases, old dogs with a disease or a syncope or recumbency or chronic anorexia for more than 4 to 5 days should always be subjected to electrocardiography. Then if you get any patient with a heat stroke or hyper temperature more than 105, always subjected to electrocardiography, because in such temperatures affect the heart. If the hypothermic, if the temperature is less than 92 or 93, 94, less than that, then in hypothermic cases also they should be subjected to electrocardiography. Then acute emergency. Acute emergency means, suppose there is a acute colic, acute abdominal accident, or there is a acute dyspnea or acute syncope or fainting, such a trauma. So these acute emergencies, besides other examination, should also be examined for the heart ailment. Then ascites. If you find a case of ascites or abdominal distension, they should always be subjected, because it can be due to the heart, it can be due to liver, it can be due to the kidney. So we have to one by one rule out the diseases. Then if the dog is used for sport or sniffer or drug detection or narcotic detection or any use as a intelligence services, so they should be always subjected to, periodically subjected to a electrocardiographic examination. And dogs showing cardiomegaly, where you suspect that the heart may be enlarged or there are some signs of the enlargement of the heart, these things should be subjected to electrocardiography. And other important thing, besides if there may no structural change in the heart, but the heart rate and rhythm is not normal, such cases should be examined through electrocardiogram. Without that, you cannot decide whether the arrhythmia is of a atrial origin or ventricular origin or supraventricular origin or a conduction disturbance or a pacemaker disturbance or SA node disturbance or AB node disturbance. So for deciding that, so you have to conduct this electrocardiographic examination so that you can take a specific therapy for the treatment. Now, some things about the electrocardiography. As I told you, electrocardiography is a very simple instrument having a voltmeter, amplifier device, and a recording device. Now, there may be many modifications, interpretations also comes and like that. But basically, they all contains the voltmeter, amplifier, recording device. And other important aspect of the electrocardiogram are leads. There you find two type of the cable. One cable has a 4 lead, another cable has a 6 lead. The cable which has a 4 lead, that is a standard cable. That is known as standard cable, in which the leads are right arm lead, left arm lead, right limb lead, left limb lead electrodes. These 4 electrodes are in this standard cable, and in a explorant cable, that is known as chest cable, it has a electrodes like B1, B2, B3, B4, B5, B5 or B6. In our case, it is only the standard cable which will give us a more of the information. If we use other leads also, that give a additional information that will be of a specialist nature, that in a referral college or referral clinic, they are more used. Now, where to place and which lead is cable is to present where? There is red colored lead that is known as right arm lead. The right arm lead is put on the right lip, near near the olecranon, here, right arm. And yellow is a left arm lead. It is placed on the elbow, proximal to olecranon, on the caudal aspect of the elbow. And the green is a left limb lead, which is put on the left limb over the patella. And then black is a neutral lead that is put over the patellar ligament on the right limb. So 4 colored leads, they are placed at 4 different places. Yellow one for left, red one for right limb, right arm, and green one for left limb, and black one for right limb. So these leads are placed at these places, and then electrocardiogram is generated. This is actually a electrocardiogram which is generated. This is, you see this figure from here, this figure, this is an amplitude of P wave. So this first positive deflection is a P wave. This is a atrial contraction. This is a summation of atrium. Here the atrial systole is there. Then there is a pause. This pause is known as PR segment. And then it will be a deflection towards down. It may be negative. That will be the Q wave. If goes up, then it is a right R wave. It again comes at baseline and comes little down from the baseline. It is S wave. And then it again a isoelectric line at baseline. This is a ST segment. And then deflection can be again anywhere. It may be positive upward or it may be negative downward. Then this is a T wave. So what we measure in this electrocardiogram, this, as I told you, this is the first segment is a P wave from here to here. This height we measure as a amplitude of P wave. From this end to this end, this bits we measure as a time taken by both atrium to depolarize. So this is a in second. This vertical is a amplitude. How much current is there? Strength of the current. Here, how much time has taken in passing of the current. So this is in seconds. and then this segment comes from here to start of Q wave. This is known as PR interval. This is important to diagnose the first degree heart blocks. Okay. Then from baseline to up stroke, this is an R wave amplitude. Down, it is a S wave, Q wave, and then again, this is second one, this is a S wave amplitude. So these are the amplitude which tells us how much force is there when the ventricle is contracted. And then this is the T wave, and between two R waves, it is known as RR interval, and from the beginning of the Q to the end of the T, it is known as interval. So these three segments, this PR interval, QT interval, and ST segment is and RR interval. These four are important segments because on this basis you can decide many things. And this is one beat is complete from between two RR interval. This is one cycle. Or anything between two P's, it is one cycle. Between two R, it is one cycle. Between two T's, this is one cycle. From one to end, this is a one cycle. So you can calculate the heart rate from this electrocardiogram. You can calculate the rhythm. You can find out where the defect is there, whether conduction defect is there, where atrium is affected, left atrium, left ventricle, right ventricle, which is affected, whether heart is getting hypoxic or heart is getting anoxic, and both you can decide from ST segment. And then heart rate you can decide by RR interval. So these are the important information which can be derived from a electrocardiogram. It is, we can go into much, there is much depth in it. It is not simple. So this is to give you an idea, because you are just a beginner. So you must have an idea what is an electrocardiogram and what it tells about it. So I'm coming to what type of information this electrocardiogram gives us. From the first information which we get from the ECG is in rhythm, whether heart rhythm is regular or irregular. Then heart rate is normal, it is decreased or increased. Then what type of heart rate irregularity is there? Rate is, suppose it is a fast, it is only fast, or it is broken down with normal also, or if it is slow, it is only slow, regularly slow, irregularly slow. So such type of information. Type of heart rhythm irregularity, whether irregularity in rhythm is periodic, it is regular or irregular. This, then type of arrhythmia, whether it is a atrial arrhythmia, supraventricular arrhythmia, ventricular arrhythmia, it is APCs, or it is a tachycardia, or it is ventricular tachycardia, ventricular asystole, or it is ventricular premature complexes. Even we can find out the current disturbance is in a left ventricle, or in a right ventricle, or is in a SA node, or in a AB node, or in a another pacemaker. So these all information can be gathered through electrocardiogram. Then size of the chamber, as I told you, it is possible in canines. As I told you, so much information can be obtained through ECG. So it means everything we can diagnose. No, we cannot diagnose everything of the heart through ECG. Its limitation is there. As with every test or every instrument, nothing is perfect. Nothing is 100%. Something weakness is there. So weaknesses of electrocardiography is that you cannot diagnose congestive heart failure through electrocardiography. Then you cannot prognose the some progress in during anesthesia and surgical progress, because when surgical anesthesia progresses, it is unpredictable. So periodic electrocardiography or regular monitoring is required during anesthesia and surgical procedure, because one-time information cannot be taken for granted. Then what is the force of contract? It is weak, it is strong, that cannot be decided on the basis of ECG. Then other thing, the wall thickness. How much thick is the wall? Left ventricular wall, right ventricular wall, whether it is hypertrophic or it is because of dilation is there. Such type of defect cannot be diagnosed with a ECG. You cannot diagnose the diseases of the wall. You cannot say definitely by ECG it is a mitral wall, or it is a tricuspid wall, or it is a pulmonary wall, or it is a stenosis, or it is a insufficiency. So these are pericardium, diseases of the pericardium, or arteries, major coronary arteries. You cannot definitely diagnose by ECG. You require other means. Suppose flow disturbances. The flow disturbances are not much important in canines. This is much more in human, but you cannot detect that the flow of the blood has obstructed in coronary vessel or in some other vessel. So this is the defect. And one thing, if you have information about a Pomerian dog, you cannot apply that data to a German Shepherd. You cannot apply that data to a Labrador. So there is a wide range of variation amongst the ECG indices in different breeds of the dog. So we have to generate the basic electrocardiographic information for every species of a dog. Wolf dog separate, Great Dane, Irish Bullfind separate, Labrador, German Shepherd, Spitz, Pomerian, Cocker Spaniel, and Pekingese. You must have a basic information for each and every species of dog. So these are the basic limitation of each. Now these defects, we cannot diagnose the wall, we cannot diagnose the pathology of vessel, we cannot diagnose the thickness of the wall. How these things can be diagnosed? The another tool with us is a echocardiography. This is an important tool which adds the information above the electrocardiogram, by which we can definitely diagnose the size of the chamber. We can even diagnose the volume of the blood in each chamber. Then we can even diagnose how the motion of the wall is there. When during diastole or systole, how the ventricular wall is contracted. We can diagnose the configuration and the motion of the different walls, tricuspid, mitral, aortic, pulmonary. All walls can be diagnosed by electrocardiography. Even we can diagnose the pericardial effusion. This is only the means by which we can diagnose pericardial effusion with certainty. Then identification of masses, tumor, if heart tumor is there, maybe at the base or maybe at the wall, this can only be diagnosed by echocardiography. And this is diagnosis of septal defect, subaortic stenosis, pulmonary stenosis, and tetralogy of Fallot. They can be, they are the congenital disease, and their diagnosis is only possible through echocardiography. Now, as there is a limitation for everything, the echocardiography does have a limitation. The first limitation is very, very expensive and sophisticated instrument. It requires the expertise knowledge, which is, and then there should be a air-free contact between the transducer and the chest, and then artifacts are very common. So one should be able to recognize whether the artifacts are, this is artifact or is a real problem. Then it needs to be interpreted in contrast with history, cardiovascular examination, and electrocardiography and other tests. In no test in itself is 100%. They all have a lacuna. So all tests should be correlated together. Then only you can get a meaningful result. Then after echocardiography, then there is a Doppler. If the obstruction is there, in blood flow obstruction is there, though this is a not major problem on a veterinary patient, this is with the human patient, this can be diagnosed by Doppler ultrasonography. Here, this red Flow means this represented red color represents the blood is flowing towards the transducer, and blue the blood is flowing away from the transducer. If obstruction is there, you can detect, and you use the standard B mode images in this type of Doppler echocardiography. Now, other important tool which can help us is a thoracic radiography. Thoracic radiography is another supportive important tool which can help us to arrive at a particular diagnosis. There should all, when you take a chest radiograph, they should be always taken in two views. One is dorsoventral, another ventrodorsal, and other third is a right lateral recumbency. Oh, sorry, it should be in three. It should be taken in dorsoventral, ventrodorsal, and right lateral recumbency. While we using setting the X-ray machine, we should set the high kbp and low MAS. It is recommended, and then exposure is ideally made at the time of inspiration. Actually, this is impossible in our patient because we cannot decide, or we cannot take the ask the animal to withhold the breath. So this is the theoretical meaning. But you can take the three views. Now, what X-ray can reveal us? If you take the chest X-ray, then what can be known? We can decide the vertebral heart score by the right lateral recumbency radiograph. And if the radiograph is showing more than 10 vertebral heart score, then there could be chances of cardiomyopathy. And then other bulges are there. Then you can find the bulges. If bulge is at 2 to 3 o'clock position, then there is a chance of left atrium enlargement. If bulge is at 4 to 5 o'clock position, there is chances of left ventricle enlargement. And if bulge is at 7 to 8 o'clock position, there is a chance of right ventricle enlargement. And if bulge is 9 to 11 o'clock position, there is a chance of right atrium enlargement. If reverse D configuration is there, then this is a right ventricular enlargement. And we can also know about the pulmonary vasculature and pulmonary edema, in which portion of the lung edema is there. Then this edema can be of cardiac origin or pulmonary origin. You can distinguish by X-ray. Now, this is these few figures to show you what happens in heart diseases when you take the X-ray. This is you first is a showing this. This is a trachea. Trachea, the angle between heart and trachea is reduced. That can be seen in cases of cardiomyopathy. Then here you see this is the heart touching the sternum and even a diaphragm. So this shows there is a enlargement. The heart is not in a normal silhouette, it has enlarged. Here you see there is a diaphragmatic contact, more diaphragmatic contact. And in this case, the vertebral heart score is 11. So there is a chance of heart enlargement. And this is a globoid type heart, not elongated one. Here, and with pulmonary edema, here is a chance of pericardial effusion or cardiomyopathy. See this one, the figure is rounding of the heart. Again, it shows the pericardial effusion or cardiomyopathy. This figure is to how to take a vertebral heart score. This is Keona. From here, long axis to the end of this heart, you take measure and put transform it on the 34 vertebra, cranial aspect, put it, and this is the bits of the heart. So count the vertebrae, which is falling under these lines, both, add them. Suppose they say in this case, this red one is coming 5.2, and again blue one coming 5. So vertebral heart score is 10.2. Here, this is a reverse D shape. So this is a right ventricular enlargement. This is a BD shape X-ray. Here, what other things can be known? This is a caudal side of the heart, perihilar region. Here you get the edema. If you get the edema here, the chances of left heart enlargement is there. So if you get this edema, this is a quite suspicious. And here, this is a ascites. You are seeing this is globoid appearance. This is the appearance of the abdomen. Ground glass. You are not able to see any organ. In this case, this is the liver. Liver is there, and this is the heart. And liver is almost of normal shape. So this ground glass appearance in this case is of a cardiac origin. So these things can be distinguished by an X. As with other modalities, the X-ray also has a limitation. The limitations of X-ray are cardiac slowly. As I told you that it becomes globoid or round or elongated. It also depends on the respiratory phase, whether your exposure has been taken, whether the heart was in a diastole or systole. So that is a major difficulty. Or in what position exposure has been made, BD, DB, or what type of chest conformation is there, or the dog is fat or not, fatty or not. Then if there is a mild cardiomegaly, it has just begin, you cannot detect through X-ray. If hypovolemia is there, suppose dehydration is there, severe dehydration is there, volume is low, in that case also heart size and slowly also changes, and you are not definitely say that it is cardiomegaly or not. Even valve pathology you cannot detect which valve is affected. Then how much severe myocardial impairment is there, that cannot be predicted by X-ray. And here, as with other modalities, X-ray findings need to be correlated with the clinical finding and other findings. Now we come, the all modalities we have discussed gives us an idea of a heart involvement when the thing has happened. Now question comes, if the disease has already taken place and therapy is very restricted, then what is the use of wasting so much of the resources? Can there be any technique by which we can detect that our pet is going to have a cardiomyopathy or any type of the disease or cardiac insult? Yes, there is a lot of development in this direction, and that development is called biomarkers of cardiac insult, where there is a little damage of cardiac muscle, maybe due to myopathy, maybe of congestive heart failure, maybe due to of the overload, ventricular overload, or maybe due to a diastolic or systolic dysfunction, we can tell us. Then first thing, which was CPKMB, creatinine phosphokinase, the MB, myocardial. In this was developed for human being when there was a severe myocardial infarction. And then other was myoglobin, then lactic dehydrogenase. Now these are the things of the past. They are not given reliance. Now we give much reliance to cardiac troponin I and anti-pro-BNP. Now let us have a look about this old one, creatinine kinase. This was a standard test for acute myocardial infarction because it contains the three different enzymes. So we have to go for a specific MB, myocardial type, the cardiac cell oriented, this is MB, and another is MM, that is skeletal cell oriented, other is BB, that is a brain cell affected. So creatinine kinase is increased in all these three diseases. So this is sub isoenzyme. We have to go for CKMB, which is heart specific. Here the problem, when myocardial infarction takes place or myocardial muscle damage takes place, it begins to rise after 4 to 6 hours. So we leave 6 hours for the damage to continue. We cannot detect. And then it reaches the peak in 24 hours and returns normal in 3 to 4 days. So its limitation is that it increases in muscle trauma, physical exertion, after operation, convulsions, and delirium. So it is of not much use nowadays, and it fails to rise abnormally in patient with a myocardial infarct. So it is the history of history. Now, likewise, myoglobin. Myoglobin was also more sensitive than CPK, and but it appears though it increases in 1 to 2 hours, and the peak is 4 to 6 hours, and returns to normal in 6 to 12 hours. Though it started increasing early, get the peak early, but returns early also. So this is a defect. If the patient is coming about 6 to 12 hours later, then this enzyme is of no value. So it has limited value. Similarly, lactic dehydrogenase, this is also of not much use nowadays. Nowadays, this is the cardiac troponin. This is cardiac muscle specific. This is the latest enzyme which is available for evaluation of the heart. It is more sensitive because it is not released by any other muscle. It is a regulatory protein, troponin I, that modulates the interaction between the actin and myosin in the heart muscle and function as a calcium switch. And there is a 3 type of the troponins: troponin T, troponin I, and troponin C. Here our more concern is T and I. In animals it is more I, which is more important. And then it rises early within 2 to 6 hours. Peak is attained in 12 to 16 hours and remains elevated for a 5 to 10 days. So window is large, diagnostic window is large. So we can use this test, and remains elevated for 5 to 15 days, 14 days. So then it is only found in cardiac muscle, not found in serum of the healthy individuals. In dog, normal dog, its label is 0.03 nanogram, even less than that. That is not detectable. But when the label rises 0.07, then it is an insult, myocardial insult. It remains elevated for 14 days. There is less chances of false positive. False negative may be there, but false positive is not there. It is more sensitive than creatinine kinase, myoglobin, and lactic dehydrogenase. Now, even more sensitive. This can detect. This is happening when the heart damage has taken place. Now there are this anti-pro-BNP. This is a more sensitive. This occurs even early when insult is myocardial muscle has stressed only. So then labels are increased. Then this anti-pro-BNP, it correlates well with the severity of heart disease. It is elevated in the valvular disease also, cardiomyopathy also, and congestive heart failure also. In healthy dog, its level is 240 p moles per liter, and levels increases more than that is considered of a heart origin, heart increase. So these are the, in nutshell, these are the 8 techniques which are used to evaluate the heart. Now, so this is the let's say I have given you a word eye view. Hello, hello. Is, hello, am I audible? Hello, hello. Is some disturbance, sir? Hello.
Sir, audible, sir?
Yes. So this is just I have given you a word eye view how to examine the heart. Please do not forget to examine the heart. Thank you.
Thank you, sir. Thank you very much for this spellbound lecture. Sir, we have some questions
Yes.
from student side. We can take few of them.
Yes, it will be great pleasure to satisfy them and answer them. We can take all, no problem.
Sir, one is the normal VHS in dog.
Normal
VHS.
VHS. The normal VHS in dog is always less than 10.
Okay. And another is, sir, about night cuffing. What is the significance of night cuffing, particularly in DCM?
Night coughing is due to because it affects the pulmonary circulation. There is a pulmonary congestion. When the temperature falls, becomes lower than the normal, then there is a more congestion in the lung. So animals start coughing more during the night, and it remains standing. That is all because when it lies down, the congestion increases. Because it is a passive congestion, so it increases. It exhibited in the form of a cough.
Sir, another question is how ECG can determine the cardiomyopathy. I think it's irrelevant. You have already taken this.
No, not irrelevant. Not irrelevant. I will answer them. In cases of the dog, it is possible. In case of the dog, it is possible to answer that cardiomyopathy has taken place because R wave, generally if it is in a small breed or toy breed of the dog, it is highest limit is 2.5. If it is a small dog and R wave is more than 2.5, then it is a chances of cardiomyopathy. If large dog and R wave is more than 3, then chances of cardiomyopathies are there. And if there is very small R wave, suppose it is 0.1, 0.2, when there and X-ray shows no pericardial effusion, then also cardiomyopathy is there. Either extreme low or extreme high with a no pericardial effusion, we can say it is a cardiomyopathy.
Another question is, sir, how how heart rate is calculated by ECG?
You just I will let you know. I will so just come to this.
Yes.
Here, when the machine is running at the rate of 25, so from here, this is 5, this is 10, 15, 20, and 25. Like that, these broad, dark vertical lines, 5 means 25 seconds, it indicates. So it means that 25 speed means the machine is moving 25 millimeter in 1 second. That represent 1 second. So one is small column, one is small difference. This is 0.04 second. So on this line we go for 0.04 second, and in this line, and if we go, then from this difference is a 0.1 millivolt. Here we measure a amplitude, what much force is there. When we say this heart rate, suppose from here to here, this is RR distance. This is suppose 5, 10, and 4, 14. This is 14, you multiply by 14, 40 by 0.04. It means 0.56 seconds means 1 beat. So you can calculate in 60 seconds how much beat will be there. Like that we can calculate.
Okay. Thank you, sir. Thank you very much. Sir, this was a very elaborative and practical oriented lecture. And right from the beginning, sir, we had more than 200 participants,
Right.
and it never went down. We had maximum 220 participants during the lecture. So it was a very good lecture, sir. It will really enlighten our veterinary graduates.
It is on their label only. It is for them.
Yes,
it was designed to give them a bird eye view. What is heart, whether should examine it or not, or leave it like that. It is just.
Yes, sir. Actually, this cardiology or heart system is always
Neglected.
left untouched. Particularly this arrhythmia and the cardiomyopathies, they are least addressed still in veterinary practice.
Right.
So we are very thankful, sir. You gave us so much time and enlighten us with the vast experience of yours, particularly in canine cardiology. I also thank our worthy Vice Chancellor and the PI and Dean of Veterinary College, Dr. Kumman, for organizing this webinar. And I would also acknowledge the enthusiastic participation the students, faculty, and other veterinarians from all other parts of India. And uh, I will I am very much thankful the IDP cell team who made this webinar possible, and with them we could organize this webinar successfully. So thank to everybody, each and everybody, and thank you, sir, for
Thank you.
being with us.
Thank you,
Thank
Dr.
you very much,
Gupta.
sir.
Thank you, Dr. Gupta, to giving me opportunity to interact with the graduate students. Thank you very much.
Thank you very much, sir.
Thank you for patient hearing. Okay.
Thank you.